Welcome to another presentation from the CV Academics Foundation, home of the AMP Honors Program.
My name is Don Hunjady. I'm one of the staff members here at the CV Academics Foundation, and it's great to have everybody with us, whether you're tuning in live or whether you're catching the YouTube or the one of the recorded versions of this. We are going to be doing a virtual job shadow or a virtual case study this evening. And it's great to have one of our board members to kick this off for us. So we have Dr. Eran Klein with us. Dr. Klein is a neurologist at the Oregon Health and Science University and the Portland VA healthcare system. He specializes in diagnosis and treatment of dementia and other cognitive disorders. And he's also a PhD, and he has that in philosophy, and his research focus on ethical issues in neurology, neuroscience, and neurotechnology. And he does some teaching, mentoring, lecturing, and bioethics work and neurology work, and practices as a neurologist, which is perfect because our case study and our job shadow for this evening is about dementia. And the case study we have, of course, be a fictitious name, but certainly bears out with what I'm sure Dr. Klein sees on a regular basis, and might hit home with any of us if our grandparents or parents start to have some signs that they might be losing their cognitive ability a little bit. And that's what we're going to talk about. So welcome, Dr. Klein, and we're anxious to hear from you. So we'll do this conversationally. It is being recorded. And if anybody has questions, pop them in the chat, and Karen will get them to us, and we'll see if we can interject them. So, Dr. Klein, let's get this virtual job shadow kicked off.
Wonderful. So Mr. Jones, Mrs. Jones is a 74-year-old woman who comes into a neurologist's office with her husband and adult daughter. She's referred to the neurologist by a primary care provider after the family noted that she's been having some problems with her thinking. The patient and her family sort of introduce themselves and sort of sit down in the neurologist's office, my office.
Don, did you have a question there?
No. Am I supposed to?
Yes, sir.
Already? Holy cow. Okay. So as we get this moving here, somebody comes to your office. They're in this case they've been referred. So what are the types of things that you want to find out, or how does, as they come in, how does a typical workup like this go when you're meeting someone for the first time?
Yeah, so I mean, I think one of the first things that I want to know when an individual and an individual and their family come in is kind of what they mean by thinking problems. I mean, people mean kind of different things by that, right? For some people that might be forgetting the names of people that they acquaintances or friends, or it might be forgetting grocery items that they they go to the store and they meant to pick up and then they forget. But other people might mean I don't know, hallucinations or being uninterested in things that they used to be interested in, right? So it's kind of a wide spectrum. So it's really sort of important to be specific when an individual or their family comes in and talks about thinking problems. So that's one thing. I also want to know, are these thinking problems something that has been going on for a while, right? For days or months or maybe even years? And have they been getting slowly worse over time, or did they sort of come on suddenly? Have they been sort of creeping up almost so slowly that people don't even notice them, or is it so sudden that it's a dramatic break from the way someone has been interacting with their loved ones or others and getting by in their daily life. So those are kind of the first things I want to know. I guess I also want to know a little bit about the people who are coming into to the visit, right? So what are their roles? How much do they know about the day-to-day of Mrs. Jones? So those are kind of the first things that I want to know.
Now, with some of those first things, how much is normal just aging process? And I think a lot of people like to pass it off as that, oh, I'm just getting older, I get more forgetful. Is it somewhat normal with aging that at least a little bit of things like, geez, I can't remember this person's name, but I don't see that person very often, or I forgot where I maybe put my car keys. Can those be normal as well, or are they always indicative or pointing at a problem?
Yeah, so that's so important. So a lot of those things can be normal. As we get older, there are some things that we don't do quite as well as we did when we were younger. So sort of our speed of processing can slow down some. And it's important to when you mention difficulty kind of coming up with people's names or forgetting kind of where they put their car keys. So those are things that can happen to people at all ages.
Thank goodness, because those two happened to me. That's why I was asking.
That's right. And it's important to know, is it something new, right? So some people will come into my office and complain about not being able to remember people's names. And then you ask them, is that something you were ever good at? And they say, no, actually, I was never good at that. And so then it's a question of finding out, well, so how much is it worse than before? And if so, kind of how much worse? So it is important to kind of distinguish between sort of natural changes of aging and dramatic or not and unusual changes of aging. Sure.
Okay. So let's keep going with Mrs. Jones here and see what happens when she starts talking with you.
All right. So she comes in and she admits that she has some memory problems, but she doesn't think that her memory problems are all that bad. I mean, she sort of thinks that it's just her getting older. And so when I pressed her about the kinds of problems that she has, she mentions that, she has to rely on a list when she goes to the grocery store, which maybe she didn't have to do so much when she was younger. She has problems sort of remembering the names of acquaintances, again, kind of people that she might run across at the store who she doesn't see very often, but feels like she has more problems with those names than before. And, she thinks that she's not real excited about coming to see me, and she thinks that really this is kind of much ado about nothing. Her family she feels are just a little bit overprotective and are overreacting to a few mistakes that she's made, and so she's not sure that this was really necessary.
And is that kind of common as well? Is that kind of the denial thing, or is just common as we get older? It's like we don't want to admit that we're forgetting things.
It's more so. It's interesting. So it's not so much denial as people who start forgetting things don't remember that they forgot. so it's really more of a that there's something about the disease itself, if we're talking about certain kinds of dementia, that prevent people from recognizing their own deficits.
Oh, that's interesting. It makes sense too. So it's really helpful then when like a daughter or somebody else comes in, can provide that second perspective. Like in this case, her daughter comes in and helps.
Exactly. It's vital, actually. Yep.
Okay.
So her daughter comes in and she sort of, speaks up and says that she thinks she has noticed some changes in her mom that she thinks are new. So she talks about a year ago, the patient's husband had to go into the hospital for knee surgery and had complications, and so was in the hospital and a rehabilitation facility for a few weeks, which means that Mrs. Jones was at home by herself, so she was there for a little while, and then her daughter came to come and stay with her. And when her daughter came, she noticed that when Mrs. Jones must have tried to cook soup or something on the stove and essentially forgot about it, must have forgotten about it, and the pot sort of burnt and was ruined. And then she sort of also noticed that her mom didn't seem to be sort of taking her medications regularly. She'd kind of go, she didn't see that her mother was taking her medications. And then when she looked at the bottles, it looked like she hadn't renewed them, so they were kind of expired. So it kind of made the daughter sort of think, maybe something's amiss here.
So, and then we'll get to the husband later, but the daughter, did she see some other things that was going on as well when she visited? And that probably helps, actually, is so often when you're just hearing or interacting on the phone or something, you find out much more when you're actually in the environment for a day or two with the person.
Yeah, so I think this is really important. This is why it's important not to just kind of know who the other individuals and their relationship is to the patient, but to kind of know how much they know about the kind of day-to-day activity. So in this case, the patient's daughter lives out of state, and so probably isn't. I mean, it depends. Different families and have different relationships, but it's entirely possible that she hasn't seen kind of the day-to-day activities of her mom, and so doesn't really know how well she does with medications or other things. So that's really important to know. And then, in this case, her husband, the patient's husband, when asked, what he thinks about her memory, sort of averts his eyes, doesn't speak up, and essentially just sort of says, I don't know if she's having problems or not. So it sort of doesn't sort of back up his daughter's worries. And there can be various reasons for this, right? I mean, it can be that he's in denial, or he is afraid to challenge his wife, and so a lot of that initial conversation is about sort of understanding the dynamics of the family, because the dynamics of the family tell you a lot about the quality of the information that you're getting about the history.
Sure. And it may be interesting for some of the people that are not yet into medicine, that the non-medical people in the audience, that all this is starting off with no diagnostic tests or anything. You're looking at the history, which can often provide a huge amount of information. So as you've gotten to this far into the case, what kind of stands out to you with the history that's been in the information that's been presented so far from the patient and her family?
Well, I mean, so medicate, the fact that she's having difficulty, what seems to be difficulty with medications, is sort of one of these instrumental activities of daily living, sort of these things that we do to sort of get by in our daily life. So, being able to manage your own medications, make sure that you order them, make sure that you take them, at the prescribed time, remember that you've taken them, is important. And it is, so I think that's one of the things that stands out here. And just the fact that her husband is reluctant to speak up, makes me a little worried that I'm going to be able to get real good information from him, or that I just need to be really careful about how I go about getting information from him. Sure.
So what other information then, as you move through the case, my guess would be that you wouldn't be able to make a diagnosis just based so far on what we found out. So what else would you want to find out, or what other information would you want?
Yeah, so I think the big thing that I want to know is just kind of how Mrs. Jones describes her daily life. So I want to kind of get a sense of how she describes it, what she thinks she's able to do on a daily basis, and then ask Mr. Jones about what he thinks may have changed in their lives over the past couple of years. So it's kind of a way to get a sense of how things are going and if things have changed. Because what I'm really interested in if we're thinking about dementia, is whether or not things have been changing over time.
Certainly. So let's find out what Mrs. Jones then has to say and how she describes what's going on with her daily life.
So when asked about her daily life, she's sort of vague in her answers. She's very personable. Sometimes she doesn't answer questions directly, but sort of jokes around and sort of pokes fun at herself or her husband, and will sometimes when asked a question that she appears like she doesn't know, she'll sort of smile and sort of turn to her husband and as if to invite him to answer. And when asked about things that have happened in the prior year, such as her husband's surgery, she seems to be kind of off by a couple months, or kind of gets the order of events wrong. So that then I'll talk to Mr. Jones, and in talking to him, he does talk about some changes that have happened over the last year or so. With a little bit of encouragement. She had always sort of paid the bills for the couple and was really just sort of meticulous about this, and this kind of wasn't part of what he did. But over the last 6 months, she's missed paying a couple bills. She says, I swear, they never sent them, right? And then she paid a bill or two twice. And so they decided as a couple to go to the bank and put their bills on auto pay to kind of prevent these sorts of things in the future. They also had to replace her cell phone several times because she misplaced it, and they never did find where it went. And when she did get, they decided when they replaced it the last time, they decided to get kind of a newer model, and she seemed to have a lot of difficulty sort of learning the new features of the phone. Sort of complaining about these sort of the new technology, and that's why she had trouble with it. She just doesn't like the new technology.
And again, taken by itself, I could probably bring you a whole row of seniors that would say the exact same thing. But you're looking for patterns or for multiple things, I would be guessing.
Yeah, that's exactly right. So in isolation, a lot of these things there could be explained away, and so when you start sort of stacking them up, that we start to see a pattern, right? So so in addition to sort of these other instrumental activities of daily living, besides medications, besides doing bills, driving is another big one. And so one of the things that I ask her about driving, and he's done most of the driving, for the couple, but she has been the one who sort of drives to the grocery store, drives to church, and he recounts this episode within the last 6 months or so, where she was had to go to the grocery store at night, and seemed to get turned around and ended up going 20 miles out of the way, and ended up having to pull over to the side of the road and call him and say, I got turned around, and can you help me figure out how to get home?
I'm a distracted driver.
And so, she when confronted with this story, she kind of gives an explanation that has something to do with, there was construction in town at the time, and so she sort of believes that there was a reason for kind of why she got turned around.
So you're acting almost as much as a detective at this point, trying to get as many clues and stuff as you can, it sounds like. So what about the information you've gotten so far and that Mr. Jones provided? How does this help pull the whole picture together, or at least start to pull the picture together for you?
Yeah, so I think one of the things I'm thinking here is that she's having problems across a range of different activities, and so while you might be able to explain one of those, it's sort of hard to explain away all of them. And I would guess that if we dig even deeper, we're gonna kind of find more issues here. And what I've tried to do is not sort of be confrontational in saying, are you still able to do your bills? Are you still able to drive? I'm not doing that. I'm more sort of engaging in a conversation about how these activities, these important activities, sort of fit into their lives, and see if they're having problems with them. See if she's having problems with them.
Which kind of points to, you're obviously a well-trained physician, but you have to use a lot of people skills and things like that, get the patient to trust you, because otherwise, if she doesn't, then she's going to be reluctant to even go any farther, I would guess.
That's right. That's right. So, the quality of the information is so important. And so I want people to feel comfortable sharing. And it's difficult. No one wants to talk about the faults and failures that they have in their life, right? So it's really important to create an environment in which people feel comfortable talking about that I'm not accusing them of being of failing or having made mistakes, but just sort of exploring kind of how things might have changed in the last year. And in my mind, I'm viewing those as mistakes, but that's not how I'm sort of presenting those to the patient and the family.
Yeah, exactly. So from all you've heard so far, what stands out to you the most about her history and about her situation?
Well, so there are a couple things that stand out. So this might seem really subtle, but the fact that when I ask her questions, she turns to him to answer those questions tells me a lot about that there's been these habits that have been developed within that couple, that he's probably been taking on more and more of the things that she used to do. And so that's kind of a hallmark of Alzheimer's disease in particular, and other kind of dementias, but Alzheimer's disease in particular is that the people close to you start to just lend a hand, and over time can sort of take over a lot of the things that you used to do on your own. And in some ways, people don't even, the couple might not even notice that couples evolve in all kinds of ways.
Right, and they're working together as a team, and
exactly.
He's picking up for what she might not be able to do, and she's probably doing the same for him in ways he doesn't realize.
That's exactly right.
So where do we go from here? What are the next things that you'd want to find out, and the next information you want to gather? It probably looks at this point like it's enough of a concern that you'd be moving forward and not just dismissing her and saying you're doing fine and this is normal and don't worry about it.
That's right. So there's enough. I have enough worry that there's some thinking problem going on. Now it's a question of what's causing that thinking problem, because there can be many things. So the things I kind of want to know now are about other illnesses, other things in her medical history. I want to know about her family history of dementia, of strokes, of psychiatric illness, of other neurologic illnesses. I want to know what medications she takes, because different medications can cause different kinds of thinking problems. I want to know if she uses substances, alcohol in particular. And I want to know a little bit about her educational history, because what we're able to do is in some ways shaped by our education.
Sure. So let's find out what we find here with Mrs. Jones in her medical history.
All right. So I find out that she takes medications for high blood pressure, high cholesterol, and hypothyroidism. She also sometimes takes Benadryl to help her sleep, and generally takes a nap every day, or sometimes two. Her balance hasn't been great for a couple of years, and particularly at night she feels kind of unsteady. But she's had some issues with her vision, and so she sort of attributes it to that. In terms of her family history, her brother and mother had memory problems in their 80s, but there's no history of neurologic illness. And when I ask about what she means by memory problems, she doesn't kind of go into it very, very much more than that. She does note that her father had depression later in his life. In terms of substances, she's never smoked, and she sort of describes her drinking as sort of social, maybe a little bit heavier in her 20s and 30s, but now pretty rare. And she graduated from high school and did a year of community college, and then for most of her life until she retired, she worked as a receptionist at a real estate company.
So anything remarkable in any of that? Again, somewhat normal for some people to take Benadryl or something to help them sleep occasionally, and some of the other things. Anything jump out so far at you in those things?
Well, so a few things. So she does have high blood pressure. She has high cholesterol, and these conditions sort of put her at risk for either past strokes or future strokes. And that's important because one of the common causes of memory disorders, of dementia, is something called vascular dementia. And as we sort of learned about earlier, it hasn't necessarily been great about taking her medication. So it may be that she hasn't been controlling these conditions very well. The sort of maybe positive thing from her history is that usually if people have had strokes, they know about it, right? They know that there was this episode where their face was drooping, or they were slurring their words, or one side of their body wasn't working well. So it's probably unlikely that she's had a stroke, but she may have had some non-stroke related damage to her brain from high blood pressure or high cholesterol. She has this diagnosis of hypothyroidism, which means she takes medications in order to replace her thyroid hormone levels. And it turns out people who have low thyroid levels can be very slow in their thinking, and this can sometimes look very much like dementia. So that's something that sort of stands out here, and we don't really know if she's been taking her thyroid medication or not, or if she's low in her levels. So that's something I'm thinking about. You mentioned the Benadryl for sleep. So many people have difficulty sleeping, particularly as they get older. Some medications are good for that as we get older, and some are bad. Benadryl is probably not an ideal choice as we get older. So that's something to sort of pay attention to.
And not to go too far off down that rabbit hole, but why would Benadryl not? I mean, it's an over-the-counter medication. So many people would think, well, if it's, I don't even need a doctor to prescribe it, it's got to be safe. So what's the potential danger in that?
Yeah. So the reason why is the same. There's a brain chemical that, at least in Alzheimer's disease, is abnormal, or that we have low levels of. And Benadryl actually works on that same system of the brain, and so it actually it essentially lowers the level of that neurotransmitter even more. And so we would want to sort of stay away from that in an older population, whereas in a younger population, in kids or young adults, it's that medication tends to be fine.
Sure, and it's probably less addicting and safer maybe for them, when it sounds like it's not for somebody in her position. Yep. So as we start to maybe get into some diagnostics and stuff now, this is all, again, for those not in medicine, we have not drawn any blood. We've not done any imaging. This is all, so far, the pictures just coming into focus with talking with the patient and getting the physical and the history and all that, which is a large component of medicine. But as we start moving into tests, let's see what you ordered in what you started to do in Mrs. Jones' case.
Yeah. So the first thing I do is I administer what's called a cognitive test, which is essentially, and you may have heard of this because it was in the news. The president was administered one of these a couple times during his presidency, and he sort of talked about that publicly. And kind of one of the most common ones is this thing called the MOCA test, or the Montreal Cognitive Assessment. And it's essentially a relatively quick screen. It takes about 5 or 10 minutes to give. And you're sort of asking a person to a number of questions, or you're asking them to do a few tasks that get at different domains of thinking. So for instance, up in that upper left corner, you're asking someone to figure out what that pattern is that starts with 1 and then A and then 2. So you're trying to ask people to shift what's called shift set, to be able to sort of go back and forth and not get stuck on 2, 3, 4. You're asking them to draw a cube to see if they have visual spatial deficit. So we remembered from the case that Mrs. Jones got lost when she was driving. And so one of the important skills, there are many skills actually that are important for driving, but one of them is visual spatial skills. So it's kind of knowing, having a sense of where things are in space. So where is that Burger King related to the turn I need to take, right? So you're testing that. You're testing language skills, make sure they can name objects, right? She was talking about having difficulty with names. You're going to ask people to remember some words, for about 5 minutes. And you're going to come back and ask her that. You're going to do some math skills to make sure her math is okay. And then you're going to ask what are called orientation questions, which is essentially, what is today's date? What day of the week is it? Where are we right now? And orientation is one of those things that that people with Alzheimer's disease in particular really struggle with. And so, in the case, if you remember, she was talking about her husband's surgery and seemed to sort of mix up the events and kind of when they happened and maybe how long ago his surgery was. And so that would be pretty characteristic of someone who's struggling with orientation. Sure.
So in her case, what does the MOCA start to tell you, or is it can this be conclusive right here? Is this just another tool again to say another box to check, and we keep checking the boxes until we get to the diagnosis?
That's right. So it's a really well tested, it's a really well validated test that's been given, millions of times. And so there are what are called norms for the test. So if you score 25 or 26 or above, you're probably normal. And if you score, below that, there's concerns that you're having problems and it's an abnormal score. But it's not a definitive test. If someone scores in the normal range, they could still have dementia, and if someone scores in the abnormal range, they could still be normal. And maybe there's something else that's causing her.
Sure. Again, like a medication or a thyroid level or those types of things.
Or maybe she didn't sleep well when, last night. She was so worried about coming in to see me that she didn't sleep, and now she's sleep deprived and just is really struggling with things that normally she would be able to do. Sure. So yes.
This sort of seems almost a little bit like an IQ test. Is it sort of related? I mean, it's not at that same level, but is it the same type of things that you're looking at, or am I way off on that? It's just when I saw, especially the lines, I remember seeing those on like IQ tests.
Right. So you are testing some similar cognitive domains, but really someone who someone is supposed to be able to do well and in the average range, sort of across a lot of different IQs. So there's a little bit of an educational component to it. So I mentioned it's 25 or 26. So if you haven't been if you haven't graduated from high school, you get sort of get an extra point for.
Gotcha.
So it's similar, but not exactly the same.
Right. Just kind of in the same family. At least it seemed to me. So how did she do on hers? What do the results tell you? And are they conclusive at this point for anything, or is more testing still needed on Mrs. Jones before we really find out what's going on?
Well, it's starting to get pretty suggestive. So the things that she struggles with are orientation and recall. So essentially short-term memory. But she does have some problems with digits backwards, which means she's having a little bit of difficulty with attention. And she may have she struggled with that first numbers and letters test, and she struggled with drawing a clock. So she may have some sort of decision making, or what we call executive function problems. So it's starting to sort of line up with an Alzheimer's diagnosis. But I still want to get a little bit more information and make sure that they're not another cause for what's going on.
Sure. So what's the next step then in the workup?
So the next step is to do a physical exam, something specific to neurology is called a neurologic exam. So here I'm less interested in sort of the heart and lungs and sort of listening to her stomach. What I'm interested in is how her nerves and brain are functioning. And so in doing a neurologic exam, I'm testing kind of her eye function. I'm testing her reflexes. I'm testing her strength. So I'm testing how well she walks. You remember from the case, she seemed to have complained about having some problems with walking. And so I really want to know is the problem she's having with her balance, is that due to poor vision? And it certainly could be. People who can't see very well can't use their vision to get around or to compensate for other issues. So so I want to know kind of what's the cause of that. And sometimes the neurologic exam can be helpful in that way. But I'm also going to do some lab work. I want to, I do want to check on her thyroid. I want to check on some vitamin levels. If people are low on vitamin B12 or vitamin D, they can start to have memory problems that look a lot like dementia. So in her case, those were all normal. And then really important, I do a depression screen. So I ask questions about depression. And not only is depression really underdiagnosed in older adults, and this is something that medicine is coming around to now, that this is really a neglected phenomenon. But it turns out that people who have depression or anxiety in particular can have lots of memory problems. So people who have depression, they have trouble concentrating. And if you can't concentrate, you can't form short-term memories. And if you can't form short-term memories, you start to have problems in your daily life. So I really want to make sure that she's not depressed, and that's what's causing her cognitive problems.
Sure. Now you mentioned the vitamin, the B12, D levels, which make a kind of some sense if those would be low. Why are you checking the kidney function and liver function and stuff? And at least on a surface level or on a light level, if you could tell us why those things would be important for cognitive and for brain, you would think,
Yep. It's a great question. So what the kidney does is it filters out, actually what both of them do is they filter out toxins. And so if you have dysfunction in either the kidney or the liver, you essentially have a buildup of different metabolites, and those are circulating in your blood, and your blood goes to your brain. And when those metabolites and toxins sort of show up in the brain, they cause abnormalities. So someone who, for instance, has kidney failure and needs dialysis, they will often have episodes when those toxins sort of build up and they need to get dialyzed. They can have confusion. Or someone who has liver failure from hepatitis or from alcoholic cirrhosis, they will get what's called encephalopathic, because the liver can't clear the toxins. So it's really important to make sure that all those systems are working too, because if they don't work, then they can affect your brain.
Sure, makes sense. So we're continuing to build the picture. We've got the neurological exam. We did the MOCA. We've got some blood work and things like that. Do we have enough at this point, or is there still more testing that you need to do to zero in? So
at this point, I still would probably like to get a picture of her brain. So I'd like to do some neuroimaging, either a CAT scan of her brain or ideally an MRI of her brain. So
and the difference between those two?
Yeah. So one of the differences is that CAT scan, the MRI can generally give you a lot more fine-grained information. What's relevant to me is that it can tell me if it's a better test for telling me if she's had damage due to that high blood pressure or high cholesterol, and if she's had any sort of strokes or in the past that we just don't know about. So CAT scan is sort of an adequate test, and can sometimes give you all the information you need in terms of telling me if her brain has started to shrink in certain areas and not other areas. But ideally, I'd like to get an MRI.
Okay, which I think was done on this case, right? And just like in normal medicine or regular medicine, we're often consulting with different people. And I think we even have another doctor to come in and eventually here in a minute or so read the, we'll have Dr. Agarwal read the MRI and provide his thoughts on it. But why don't you talk a little bit what you found here?
Well, maybe I'll have him jump in. The MRI gets done, and there's some abnormalities that tend to be characteristic of what we see in Alzheimer's disease. And so, but sometimes it's helpful to consult with what's called a neuroradiologist, so an expert in radiology of the brain, and to sort of interpret, because it's like there's no one cognitive screening test that is going to absolutely diagnose dementia. The imaging may not give an absolute diagnosis of different kinds of dementia, such as Alzheimer's disease, but it can certainly point in that direction. So I'm going to walk down the hall in pre-COVID times and talk to Dr. Agarwal.
Sounds good. And I think we have the images too that we can show here as Dr. Agarwal joins us and talks about what we're seeing.
Yeah. Can you all hear me?
Mm-hmm. Welcome. Yeah. Thanks for being here with us.
Yeah, thank you, Dr. Klein, for such a wonderful presentation of this case. Walking down all the clinical presentations and how you reach a particular diagnosis. I have some images here for this patient, and my role comes in when the patient's doctor, somebody like Dr. Klein, advises an MRI or an imaging test on the patient. And as he said, the very basic idea for getting a scan is to rule out something obvious in the patient. So, this patient could be having a tumor, for example, which could be causing the cognitive impairment. She could be having a subdural hematoma. She could be having, a previous stroke, which might be, causing her cognition to not be at the level where she wants it to be. Or she could be having something that Dr. Klein mentioned earlier, something known as vascular dementia, in which the patient has, lots of chronic cerebrovascular ischemic disease, which is usually caused by hypertension, other vascular risk factors. And she does have, if we look at these MRI images, she does have these hyperintensities in the periventricular regions, which are usually caused by chronic cerebrovascular ischemic disease. And if this is present in sort of more extensive fashion, then this could be something that could be causing her cognitive impairment. But with this level, it may or may not be the cause, or may at least contribute to her cognitive impairment. But that certainly does not seem to be the only cause for the level of cognitive impairment that this patient has. But we are not seeing any other, obvious cause. She does not have any big bad stroke. She is not having a tumor here, and she does not have a subdural hematoma that could be causing her cognitive impairment. So basically, her MRI of the brain structurally looks okay. Now, she could be having something, as Dr. Klein mentioned earlier, shrinking of her, brain structures, which in the case of Alzheimer's disease are usually the medial temporal structures, the hippocampi, or the parietal lobes. We can certainly come back to that. But before that, could you advance the slide for me? Yeah, so before that, before coming on to the other, MRI techniques where we can actually measure the volume of the brain parenchyma, we can do something like an FDG PET of the brain, which tells us about the metabolism of the brain. And in Alzheimer's disease, typically the areas that show decreased metabolism are the parietal lobes. Dr. Klein has mentioned that the patients in Alzheimer's disease can have visual spatial problems. They have trouble finding their way. So this, the parietal lobes in the brain are responsible for visual spatial function. They tell us where we are, in space, where to go. So decreased metabolism of the parietal lobes is a feature that is common in Alzheimer's disease. And on this FDG PET of this patient, we see that there is decreased FDG uptake in these parietal lobes. For reference, I have this normal FDG here, and you can see that the parietal lobes do not have any abnormality on these normal images. So this decreased metabolism or decreased uptake of the tracer in the parietal lobes definitely tells us that, you know, there is some parietal lobe hypometabolism, and this patient could be having Alzheimer's disease. Next slide for me, please. And again, we have this special MRI now, which is called the arterial spin labeling. And this special technique, this special MRI technique actually tells us about the perfusion in the brain. And sometimes this hypoperfusion is taken as a surrogate for hypometabolism. And we've been using this arterial spin labeling technique in place of FDG to tell us where we could be having hypometabolism related hypoperfusion. So again, on this patient's ASL, you can see that there is decreased perfusion in the parietal lobes bilaterally, which is also seen on these coronal images here. So again, on FDG PET, we saw that there was decreased metabolism in the parietal lobes, and this same information is also seen on these arterial spin labeling or ASL MRI images where there is decreased perfusion in bilateral parietal lobes.
Now, I even hesitate to go there, but you can see all this. Is there anything you can point to that shows some of these? Are these obvious signs? Are these easy to spot? Or are these real subtle pickups that only somebody that like you that's been doing it for many years can spot?
So on the previous slide where you know, there was that FDG PET, again, you could see that there is uniform uptake of tracer everywhere. You know, there are no areas that look asymmetric or sort of you know, different from others. But here you can see that this area shows normal uptake, but this area shows like a you know, is darker than other areas. So this is normal uptake here, but here you can see that the uptake is decreased. So this kind of asymmetry and non-uniformity of images is what makes us think that, you know, this particular area is not taking the tracer as it should. For example, you know, in a normal image, you can see that there is, you know, uniformity of tracer uptake, whereas here it is sort of heterogeneous, and there is this patch of decreased uptake of the tracers. And the same thing we see on the ASL image on the next slide. If you could advance the slide for me. So this is normal uptake. You can see that there is, you know, normal uptake or normal signal on ASL images here, but here we can see that there is, you know, this blue area is the area which shows us that this area does not have the perfusion of the normal brain as other areas have, or other areas, you know, this area is supposed to have. So this is normal ASL signal, and here we see that there is asymmetry or sort of, you know, a patch of decreased signal or decreased perfusion, so to speak, that we can see on this special MRI technique that is used to map the perfusion of the brain. Does that make sense?
It certainly helps to. I mean, it is obvious when you're doing it every day, you can spot these things obviously way quicker than we do, which is often, I'm sure, your role in coming into a case like this to assist. It's not only one physician, but multiple physicians often working together in a team to come to a diagnosis like this.
Absolutely. It's a very multi-modality and multidisciplinary approach to these patients. You know, as Dr. Klein, you know, he does all the clinical workup, and then he comes to you know, certain conclusions, and then he orders, you know, lab tests and imaging tests to rule out other things. You know, by blood test you could rule out, you know, hormonal problems, you know, other infectious problems, and then by doing structural imaging we can find out whether or not the person has a structural cause for the cognitive impairment that the patient has. For example, as I mentioned earlier, could be having a tumor, they could be having previous strokes, they could be having, you know, hemorrhage in the brain, subdural hematomas, which are, you know, common causes for the patient to lose their cognition or have decreased cognition. So the structural imaging or imaging of the brain is used to sort of rule out those causes, and then by using special techniques, we can zero down to see what other possibilities are. For example, here, where we have decreased, you know, metabolism in parietal lobes and decreased perfusion, we certainly are moving towards the diagnosis of Alzheimer's.
Right. That also. In this. So, is there anything other tests or anything else that we need, Dr. Klein, to help evaluate, or did you have another another slide to go through here? I don't want to
Yeah,
skip ahead of you.
on the earlier slide, we mentioned that there could be shrinkage of certain areas of the brain. And this is one other special MRI that we use, in which we calculate the volume of different structures of the brain. And this is, one such technique called the volumetric MRI of the brain. And here, visually, we can see that there is, some decreased volume of bilateral hippocampi. These are the hippocampal, these are hippocampi. This is one hippocampus. This is the other hippocampus of the person. And visually, it does look like there might be some decreased size of these hippocampi. But then we have this special MRI in which we can actually calculate the volume of these structures and put it on a sort of a map of normal patients. So if you could advance one more slide for me. Yeah. So here we have this table in which we have plotted the volume of the hippocampus of this patient against a normative database. So on this normative database, we can see that the hippocampus of this person is well below the 25th percentile for that age, which sort of corroborates what we saw visually. A lot of times, visual assessment is either not possible, or is the volume loss is so subtle that we're not able to see how much volume loss there is. So this kind of technique where we can plot the volume of that person's hippocampus or parietal lobe, temporal lobe on a normative database gives us more confidence as to whether or not this patient is having volume loss for that particular age. So we could do structural MRI to look to exclude structural causes, look for decreased metabolism in different areas of the brain, and then we can do something like volumetric images or volumetric MRI, in which we can actually see the shrinkage or the volume loss of structures that we know happens in an Alzheimer's disease.
Gotcha. So at this point, then, Dr. Klein or Dr. Agarwal, either of you, do we have enough information to make the diagnosis of Alzheimer's, or is there still something else that you'd want to get?
No, at this point, this is we've gotten probably all the information that we need to be pretty confident in our diagnosis.
Okay.
And it's wonderful to have the consult from Dr. Agarwal. And as you mentioned, medicine is really teamwork, and you're really relying on the observations of other clinicians to help figure out this puzzle for this particular patient. But in this case, really the history is very consistent with Alzheimer's disease. The imaging all sort of points in that direction, and we've done a lot of tests to make sure that we're not missing something, that there's not some other thing that might be causing this. So at this point, unfortunately, the diagnosis that I'm going to give her and talk to her and the family about is that she likely has is in the first stage of mild Alzheimer's disease.
So let's talk a little bit about what that means then. What can we do for it, and what can, like most things in medicine, I guess there's no cure. It's more of a management and hopefully in trying to keep it from getting worse. But talk to us about what the diagnosis is confirmed something's going on, but what do we do about it?
Yeah, so now the ship turns to figuring out what to do, and kind of the first thing I want to do is make sure that the patient is safe and the family are safe. So she had started to have trouble with driving, and this is something that Alzheimer's disease will affect people's driving, and so I want to make sure that she's still safe to drive, and whether that means talking to her and the family about not driving anymore, or being evaluated by the DMV for whether or not she's still safe to drive. I want to ask about whether or not there are guns in the house, and so that's a definite safety issue for some people.
Sure, something I would have never even thought of that, but that certainly makes sense.
Yep. In terms of medications, there are approved medications for Alzheimer's disease. They don't stop the disease, and there's controversy about kind of the extent to which they even slow the disease, but they can help with treat some symptoms. And so I'm going to talk to the family about whether or not the patient and the family about whether or not she wants to start on one of these medications. And then I just want to do some serious education about what is this disease? What can she expect? What can the family expect? And so as her clinician, I want to give her educational resources, and I want to point her in directions where they can, after they leave my office, find other good quality information about the disease. So I might direct her and her family to the Alzheimer's Association in her community, which is a great resource. Now,
would you continue seeing her, or would this go back to her primary physician? And I guess along with that too, is a neurologist the only person that treats dementia, or can her primary handle this after this diagnosis is made?
Yeah. So in this case, I would probably, there was a referral made to me as a specialist. And I think in this case, I would probably have her return to be cared for by her primary care provider. If there were uncertainties about the diagnosis or sort of complicated behavior, people can have hallucinations or other sorts of things that go along with their dementia, and so I might stay involved to sort of help at that point. As far as a neurologist as the diagnostician, you can be primary care doctors diagnose dementia, psychiatrists can diagnose dementia, geriatricians, so people who are specialized in treating older adults can diagnose dementia. Typically, the neurologist sort of gets involved if things aren't kind of clear, if there's kind of conflicting signals and you have a kind of complex case, and that's kind of typically where the neurologist kind of steps in and can offer some expertise.
Sure, and it seems like until the imaging, she might have been a little bit borderline, and probably that's why the doctor, the PMD, sent her to you, because he wasn't confident or wasn't certain in making the diagnosis on his own with the information that he had.
Yep, I think that's right.
Yeah, and it's certainly nothing wrong with that. I applaud physicians that certainly, stay and understand what they do well, and then bring in other people to help what they do well with. We've got just a couple minutes left. I don't know, Karen, if there was any questions that could put in the chat, but we certainly want to give people an opportunity here. I saw something flash up. If I can bring it up here. Is this a question here? Okay, so the terms dementia and Alzheimer's have been somewhat interchanged. Is Alzheimer's a type of dementia? But I have heard that dementia is at times associated with a change in mood, kindness, things like that. Is this true?
Yeah. So what how I tend to describe it is that dementia is the broader term, and then there are different kinds of dementia. The most common kind of dementia is Alzheimer's disease, and then the second most common is sort of stroke-related or vascular dementia, and then you can have kind of Parkinson's disease-related dementias. So it's kind of the difference between a bowl of fruit is dementia, and then the different fruit, the apples, the oranges, the bananas, are the different kinds of fruit in that bowl. So that's sort of the relationship. And in terms of what can dementia affect, it certainly can affect people's outlook on life. There's an association of depression in people who get dementia. So understanding not just those cognitive domains, but also sort of the emotional domains are really important to pay attention to.
Sure. Another question we have, and is very interesting to me as well. I think often associate this disease with elderly and older people, but can dementia start like, say, under 50 or in the 40s or things like that? I would guess it's probably less common, but is that a possibility, or maybe you see it routinely?
So it's exceedingly rare to have dementia in people who are under 50. Usually, if people are having cognitive problems, it's probably not from dementia. It's probably from something else.
Okay.
But there are some kinds of dementia so Alzheimer's disease tends to be a diagnosis of mostly 70s, 80s, and 90s, and sometimes you can get it in 50s and 60s, but in that case, it's rare, and there's often a strong family history of people getting dementia when they're young. So that tends to be a tip-off. There is a form of dementia called frontotemporal dementia that tends to affect people in their 50s and 60s, but it looks very different from Alzheimer's disease. So it'll often get diagnosed differently.
Okay, let's get one last question in here before we have to go. Is there a typical prognosis for dementia patients, or is it unique to each individual, or do you kind of see a course that many follow with timelines and things like that?
So there really is a great deal of variability. I think there are averages. So I think that, the average from diagnosis to the time someone dies tends to be in the 5 to 10 year range, 7-year range. But there really is great variability. Sometimes, unfortunately, the disease moves very quickly and over a few years. And sometimes I have patients who've had Alzheimer's disease for more than 10 years. So it really does vary.
Okay. One more popped up here. Since depression is such a high prevalence, especially in these COVID days, I added that, the person didn't, but with depression being high prevalence, would you recommend someone see a psychologist or psychiatrist to help alleviate this? I guess that's their question. My question is depression a precursor in any way to Alzheimer's? So kind of two questions, somewhat related there.
Yeah, so it's a great question. So oftentimes it's interesting. People will come to be treated by a mental health provider, a psychiatrist or psychologist, and they will notice that they need to go see a neurologist. And sometimes people will come to a neurologist for memory problems, and they will then direct them to mental health care. And so again, this kind of points out that the importance of sort of teamwork in medicine to sort of figure out what's going on. I think in terms of I don't think every time someone has memory problems, they should first go see a psychologist or psychiatrist. I think it just really depends on the whole picture of what they're presenting with. But a neurologist or a primary care physician should certainly keep that in mind, that could be a possible cause of memory problems as they're trying to figure out the diagnosis.
And they're asking too about the high prevalence of the depression and stuff. And I guess it would matter how severe and how long it goes. Obviously, if somebody's having depression for 6 months or a year, it's something to obviously go get treated. If you have a weekend or two where you just are not the happiest person on the planet, that's maybe not quite yet the time to go get help, I would imagine. It's again a prolonged type thing, or at least a month or two, something like that, would you say?
Yeah, I mean, it kind of depends on the severity of the depression, right? So, someone who is significantly depressed, they should seek care right away. If it's milder, then there are specific diagnostic criteria for sort of how long you have to have symptoms of depression before you are diagnosed with depression. So. Sure.
Anybody suicidal or unable to get out of bed to work or anything, that's obviously something that should be seen much sooner than somebody that's just not feeling their normal self, I would imagine.
Yep.
What a great topic. And for people maybe going into medicine, gives you a glimpse of how a workup goes, and it might not even be like you think it would be, where it's just ordering blood tests and ordering MRIs and stuff like that. There's a lot more that goes into it. Hopefully we can continue doing this. My thanks to Dr. Klein and also Dr. Agarwal for showing us his end of things as well. Hopefully everybody on the call tonight got a lot out of this, and it will be posted. So if you missed something, you want to hear something again, you'll be able to see it online in just a little while. Dr. Klein, thank you very much. It was really, really interesting to hear and find out some information on this.
Thank you for having me.
Yeah, thank you for putting this together. Thank you.
Very, very good. Thank you as well, Dr. Agarwal. Everybody, have yourself a great evening and a decent weekend here coming up. keep watching for more of these in the coming weeks and months.
This has been a presentation of the CV Academics Foundation, home of the AMP Honors Program.